Every 65 seconds, someone in America is diagnosed with Alzheimer's. By the time this video ends, roughly a dozen more families will have heard that word. And for a real, documented number of them, the cause traces back to something nobody thought to question: a bottle on the bathroom shelf, refilled every month without a second thought, because a doctor prescribed it and a pharmacist filled it. I'm Dr. William. In 15 years of practice, I have sat across from families who came in convinced they were watching ordinary aging. Mom keeps asking the same question 3 times. Dad got lost 2 blocks from his own house. And almost never, in that first conversation, does anyone bring up the orange bottles lined up on the kitchen counter. Nobody thinks to. A doctor prescribed it. A pharmacist filled it. It must be fine. Here's what years of research are now telling us: it isn't always fine. Not because these drugs are poison, and not because you should panic and stop taking anything you've been prescribed. Please don't do that. But because a specific group of extremely common medications have been linked, in study after study, to changes in memory and thinking that get written off as just getting older, when the real story might be sitting in the medicine cabinet. I want to be upfront about something before we go further, because it separates this video from a lot of what circulates online. Almost everything you're about to hear comes from what scientists call observational research, large groups of people tracked over years, comparing those who took a medication to those who didn't. That kind of research is powerful, but it doesn't always prove a drug directly causes dementia. Sometimes the people prescribed a certain medication were already at higher risk for other reasons, and the drug just happens to be along for the ride. I'll flag that distinction honestly as we go, including one entry on this list where the popular fear runs well ahead of what the evidence actually shows. Today I'm counting down 9 medications that neurologists and researchers are watching closely for their connection to dementia risk, from the ones that quietly slip under the radar to the one I consider the most serious of all. Stick around for number 1, because the research behind it surprised even me. And before we start, tell me in the comments your age and which of these, if any, you or someone you love is taking. I read every comment, and it shapes what I cover in future videos. Let's start at number 9. Number 9, diphenhydramine, the drug you know as Benadryl. It's the pink tablet reached for at the first sign of a sneeze, a sleepless night, or a mosquito bite. It sits on an open shelf, costs almost nothing, and requires no prescription, which is exactly why almost nobody questions it. Diphenhydramine belongs to a class of drugs called anticholinergics. That's a technical term for a simple mechanism. These drugs block acetylcholine, a chemical messenger your brain relies on to form new memories and stay mentally sharp. Your brain naturally produces less acetylcholine as you age, which means the same dose that barely registers in a 30-year-old can hit a 70-year-old brain far harder. The structure that takes the brunt of it is the hippocampus, the small, curved region responsible for turning short-term experience into lasting memory. Think of acetylcholine like the librarian in a busy library, constantly checking new material in and filing it where it belongs. Block that librarian and the books, your memories, just pile up at the front desk, half-shelved, easy to lose. That's roughly what a nightly anticholinergic dose is doing, quietly, for years. A landmark study out of the University of Washington, published in JAMA Internal Medicine in 2015, followed nearly 3,500 adults over the age of 65 for close to a decade. People who use strong anticholinergic drugs, including diphenhydramine, regularly enough to add up to 3 or more years of cumulative daily use had a 54% higher risk of developing dementia than those who barely used them at all. And the effect appeared to build with dose. The more you took, the steeper the curve. I've had patients describe taking just a Benadryl every night for a decade to fall asleep, never once connecting it to the word-finding trouble that crept in a few years later. It's an easy connection to miss, because the pill feels harmless and the memory changes arrive slowly, one misplaced word at a time. If you reach for anything labeled nighttime, PM, or allergy relief, check the ingredients. Diphenhydramine hides under a lot of brand names, including many store-brand sleep aids that don't advertise it clearly on the front of the box. Newer antihistamines like loratadine don't cross into the brain the same way and carry far less of this risk. Never stop a medication on your own, but this is absolutely worth a conversation with your doctor or pharmacist. Number 8, proton pump inhibitors, and this one is more complicated than the headlines suggest. Drugs like omeprazole and esomeprazole shut down acid production in the stomach and are handed out constantly for heartburn and acid reflux. Some older studies raised alarm here. A widely cited 2016 German analysis and a couple of claims-based studies out of Taiwan and Korea reported anywhere from a 20 to 50% higher dementia risk among long-term users, and the proposed mechanism made sense on paper. Lower stomach acid can reduce absorption of vitamin B12, a nutrient your nerves depend on. But here's what a responsible summary has to include: the newer, better-designed research has walked a lot of that back. A large 2023 prospective cohort study in the journal Gastroenterology, and a separate analysis from the atherosclerosis risk in communities study published the same year in Neurology, both failed to find a meaningful link between PPI use and dementia once researchers controlled more carefully for other health conditions. A 2023 systematic review in the British Journal of Clinical Pharmacology reached a similarly cautious conclusion: the evidence is inconsistent, and much of the earlier alarm may reflect the fact that people who need these drugs long-term tend to have other health issues that independently raise dementia risk. So where does that leave you? PPIs are not risk-free forever medications. They're linked to real issues like B12 deficiency and bone density loss with long-term use, and the general medical advice is still to use the lowest effective dose for the shortest reasonable time, often stepping down to a gentler H2 blocker like famotidine once symptoms are controlled. But the dementia connection specifically is one of the shakier claims still circulating online, and it's worth knowing that before you panic about a medication that, for many people, is genuinely necessary. If you've been on one for years without ever revisiting whether you still need it, that annual review is the real action item here, not fear. Number 7, oxybutynin, the bladder medication sold as Ditropan. This one is prescribed to seniors dealing with an overactive bladder, the sudden, urgent need to find a bathroom that can reshape an entire day. The relief it offers is real. But oxybutynin is also a potent anticholinergic, and unlike some drugs in its class, it crosses easily into brain tissue. The same 2019 JAMA internal medicine study I want to mention here, led by researcher Carol Coupland at the University of Nottingham, following more than 250,000 people over roughly a decade, found that among all the anticholinergic drug categories studied, bladder antimuscarinics like oxybutynin were among the classes most strongly tied to increased dementia risk, with roughly a 50% higher risk among the heaviest users. That puts it in the same tier of concern as some of the drugs we'll get to later on this list. Patients rarely connect the dots. They were told a pill would calm the bladder. Nobody mentioned it might also be dimming their memory. The fog gets chalked up to age, forgetting a name, losing the thread of a conversation, and by the time anyone thinks to question the prescription, real ground has often already been lost. If you're on oxybutynin and have noticed your thinking getting foggier, that's worth flagging. Newer drugs like mirabegron work through a completely different pathway that doesn't touch acetylcholine at all, and for many older adults it offers similar bladder control with far less cognitive downside. Bring it up at your next appointment. You shouldn't have to choose between your bladder and your brain. Number 6, statins, and this is the one where I want to slow down, because the popular fear here runs ahead of the evidence. Statins like simvastatin and atorvastatin are among the most prescribed medications on Earth, and back in 2012 the FDA did add a warning label about reports of short-term memory fog and confusion in some users. That warning is real, and it's why the fear took hold. The theory behind the fear made a certain intuitive sense. Your brain is roughly 60% fat and relies heavily on cholesterol to build myelin, the insulating layer wrapped around nerve fibers that let signals travel quickly and cleanly. Drive cholesterol down hard enough, the thinking went, and you might starve the brain of a raw material it needs. But when researchers actually tested this with rigorous, longer-term studies, the picture calmed down considerably. A 2021 study in the Journal of the American College of Cardiology followed more than 18,000 adults over 65 for nearly 5 years and found no increased risk of dementia among statin users compared to non-users. Multiple systematic reviews, including ones covering randomized controlled trials specifically, have found no consistent evidence that statins cause cognitive decline, and several large observational studies have actually found the opposite, a lower rate of dementia among long-term statin users, likely because protecting your heart and blood vessels also protects blood flow to your brain. The honest takeaway, the memory fog some people report is usually mild and reverses once the medication is stopped or adjusted, and it appears to affect only a small subset of users. If you've noticed that fog, it's worth mentioning to your doctor, since there are different statins with different properties. But if you've been avoiding a statin your doctor recommended purely out of fear it will cause dementia, the current evidence does not support that fear, and stopping a heart-protective medication carries its own very real risks. Number 5. Benzodiazepines, lorazepam, diazepam, alprazolam. These are among the most commonly prescribed drugs for anxiety and sleep, working by boosting GABA, the brain's natural calming signal. The relief can feel immediate and profound. The concern is what happens with sustained use. This is genuinely contested scientific ground, and I think you deserve to hear both sides rather than just the scary half. Several meta-analyses pooling dozens of studies have found associations between benzodiazepine use and dementia risk, with odds ratios ranging roughly from 1.3 to nearly 1.8, meaning 30 to 80% higher risk in the pooled data. But a 2024 umbrella review in the journal Biomedicines that re-examined this entire body of evidence rated the underlying studies as low quality overall, and a large Swedish population-based imaging study published that same year in BMC Medicine found no clear association once reverse causation was accounted for, meaning some of the link may reflect people already developing early, undiagnosed dementia symptoms and then being prescribed a benzodiazepine to manage the resulting anxiety or sleep disruption, rather than the drug causing the decline. What's not in dispute is that benzodiazepines cause real sedation, slowed thinking, and fall risk in older adults, and that they're genuinely difficult to stop once your body adapts to them. Many patients describe a kind of emotional flatness after months on these drugs, not quite themselves, moving through the day a step behind. And the exit can be the cruelest part, stop suddenly, and the anxiety or insomnia the drug was treating often comes roaring back even stronger, which is exactly why so many people end up staying on them far longer than originally intended. If you've been on one for more than a few weeks, never stop abruptly, that can be dangerous, even life-threatening in some cases. Work with your doctor on a gradual taper over weeks or months, and ask about alternatives like buspirone or cognitive behavioral therapy for insomnia, which can rebuild sleep and calm without the same dependency risk. Quick pause, if this is helping you connect some dots, tap that like button. It helps this information reach more families who need it. Now, back to the countdown. Number 4, amitriptyline, an older antidepressant sold as Elavil. This drug earns its spot on the list through sheer versatility. It's prescribed for depression, nerve pain, migraine prevention, and sleep, which means an enormous number of people end up on it without necessarily thinking of it as a psychiatric medication at all. Underneath that versatility, amitriptyline is one of the strongest anticholinergics still in common use, blocking acetylcholine even more aggressively than diphenhydramine. That same 2019 JAMA Internal Medicine Anticholinergic study found that antidepressants in this older tricyclic class carried some of the strongest associations with dementia risk among all the drug categories examined. Patients in the highest exposure group saw roughly a 50-fold difference in cumulative dose compared to the lowest, and the dementia risk climbed accordingly. People taking a small nightly dose for years, for something as ordinary as chronic back pain, often have no idea this is part of the conversation. If you or someone you love takes amitriptyline, it's worth asking your doctor whether a newer option makes sense. For nerve pain, duloxetine or gabapentin often provide similar relief with a much lighter anticholinergic footprint. For mood, newer antidepressants like sertraline are generally considered safer for long-term brain health in older adults. Number 3, paroxetine, sold as Paxil, the SSRI that doesn't quite fit with the rest of its family. Paroxetine belongs to the SSRI class, generally considered the gentler, more modern option for depression and anxiety. But it has a quirk that sets it apart from close relatives like sertraline and escitalopram. It carries meaningfully more anticholinergic activity than other SSRIs. Because of this, it's one of the few antidepressants included on the American Geriatric Society's Beers criteria, a formal list of medications considered potentially inappropriate for older adults specifically because of this kind of risk. Researchers have flagged this repeatedly in reviews of anticholinergic burden in aging populations, noting that among SSRIs, paroxetine consistently shows the strongest links to cognitive side effects like slowed recall and attention difficulty in older users. There's a real irony in it. A medication meant to protect mental clarity may, in a subset of patients, be working against it. If you're on paroxetine and you're over 65, that's a reasonable thing to bring up with your prescriber. Sertraline and escitalopram are generally considered gentler alternatives for older adults, without sacrificing effectiveness for mood and anxiety. Number 2, antipsychotic medications, quetiapine, risperidone, olanzapine. I want to be very precise here, because this is a case where the real story is arguably more alarming than a simple dementia risk statistic. These drugs were developed for serious conditions like schizophrenia and bipolar disorder. But they're frequently prescribed off-label, in nursing homes and at home, to manage agitation, aggression, or sleep disruption in people who already have dementia. The FDA issued a black box warning, its most serious safety alert, for these drugs back in 2005, later extended to the entire class in 2008, after a meta-analysis of 17 clinical trials found that elderly patients with dementia who took atypical antipsychotics had roughly a 60 to 70% higher risk of death during the study period compared with those on a placebo, driven mainly by heart-related events and infections like pneumonia. This isn't a theoretical dementia risk statistic. This is a documented increase in mortality, in the very population these drugs are most often given to. And yet prescribing has continued for years, largely because there's no FDA-approved medication for dementia-related agitation, and families and caregivers are often desperate for something that works when a loved one is frightened, combative, or awake and pacing at 3 in the morning. I understand that desperation. I've sat with families in exactly that position. But the honest research shows that for a condition already defined by cognitive decline, one of the most common treatments carries a measurable mortality cost, driven mostly by heart problems and infections like pneumonia, not by the agitation itself. If a parent or spouse with dementia has been placed on one of these medications for agitation rather than a diagnosed psychiatric condition, it is absolutely worth asking the prescribing doctor what non-drug approaches have been tried first, things like structured routines, reducing overstimulation, and addressing pain or infection as hidden causes of agitation, and how the risks are being weighed and reviewed over time. Which brings us to number 1, the medication I consider the most serious entry on this entire list, and it isn't the one most people expect. Number 1, opioid pain medications. Drugs like oxycodone, hydrocodone, and fentanyl are prescribed for pain, often starting after a surgery, a fall, or a worsening chronic condition, and in an aging population dealing with arthritis and back pain, that adds up to an enormous number of prescriptions. What makes opioids stand apart from everything else on this list is that the research shows danger on 2 separate fronts at once. On cognition, a UK biobank analysis published in 2024 in the American Journal of Geriatric Psychiatry followed older adults with chronic pain and found that regular opioid use was associated with roughly a 70% higher risk of all-cause dementia, and more than double the risk of vascular dementia specifically, compared with non-users. A separate large Israeli cohort study found a similar pattern in adults aged 75 to 80. Researchers are still working out the exact mechanism, but changes in brain regions tied to memory and reward have shown up in the neuroimaging data. On mortality, this is the part that alarmed me most while researching this video. A 2023 Danish nationwide study presented at the Alzheimer's Association International Conference followed everyone in the country diagnosed with dementia over a 10-year span. Older adults with dementia who started an opioid saw their risk of death within 6 months roughly quadruple compared with those who didn't, and in just the first 2 weeks after starting, the risk of death was more than 10 times higher. Among those started on a fentanyl patch specifically, nearly 2/3 died within 6 months. To be clear, this doesn't mean opioids should never be used. Pain that goes untreated has its own serious consequences, including worsening confusion, immobility, and quality of life. There are absolutely situations, like recovery from major surgery or advanced cancer pain, where the benefit clearly outweighs the risk. But it does mean that starting an opioid in an older adult, especially one who already has any degree of cognitive impairment, deserves a careful, deliberate conversation about dose, duration, and close monitoring in those crucial first 2 weeks, not a routine prescription handed over at the end of a rushed appointment. Here's what I want you to take from all of this. None of these 9 medications are inherently reckless, and none of them mean you or someone you love is destined for memory loss. Correlation in a population study is not the same as a guaranteed outcome for one individual, and every medication on this list exists because it solves a real problem for real people. Pain gets managed, anxiety eases, hearts keep beating steadily. What matters is awareness, knowing which drugs carry this kind of risk, reviewing your full medication list with your doctor or pharmacist at least once a year, and never, ever stopping a prescription cold on your own based on a video, including this one. If someone in your life takes several of these at once, that layered exposure is worth a real conversation, because anticholinergic effects in particular tend to stack. 2 mild ones together can add up to the burden of one strong one. Many geriatric pharmacists now specialize in exactly this kind of medication review, sometimes called deprescribing, and it can genuinely change someone's trajectory. Ask your doctor whether that kind of review is available to you. If this video helped you understand what to ask your doctor, share it with someone who needs to see it, subscribe for more research-backed breakdowns like this one, and tell me in the comments which of these 9 surprised you most. I'll see you in the next video.